I'm Dr. Raj Sundar, a family physician and a community organizer. You're listening to Healthcare for Humans, the show dedicated to educating you on how to care for culturally diverse communities so you can be a better healer. This is about everything that you wish you knew to really care for the person in front of you, not just a body system. Let's learn together. Welcome to episode 2 from the Health Conference. Go back and listen to episode 1 if you want a little more context to this. There's a question that haunts the hallways of every health tech conference, health conference included. How do you measure what matters? Walk through health and you'll hear, quote unquote, ROI, repeated like a mantra, return on investment. And I know this metric well. I've studied it and know its importance. But it is a metric that decides which innovations live and which ones die. But when a farm worker in South LA finally gets a skin lesion looked at after years of no access, when a mom doesn't have to take 3 buses across town to see a specialist, or when a rural Colorado physician suddenly has an army of specialists in his pocket, what is the value on that? Is ROI enough to capture that? Last episode, I talked about scalable privilege, the idea that technology could take what's only accessible to people with resources and bring the floor up for everyone. Today's conversation is another example I found of what actually looks like when somebody bothers to measure it. You'll meet Jomo, a healthcare data veteran who spent 30 years in this work. He introduced me to the idea of return on value. It expands beyond traditional ROI to measure return on impact, return on innovation, and just return on individuals. He's been working with Safety Net Connect, an eConsult platform that's transformed specialty access in LA County. In 2010, the wait time to see a dermatologist for Medicaid patients was 14 months. Melanoma just waiting to be seen for 14 months. Now, resolved in 2.4 days on average, 78% of consults never need a specialist visit. They get handled through the platform. $91 million in value created annually. The funny thing is when Jomo first asked the founder how much value they were generating, the answer was, I don't know. Sometimes the people doing the most important work are too busy doing it to prove it matters. Can technology take what's only accessible to the privileged and make it available to everyone? Jomo has the numbers that say yes. Here he is. Thanks for meeting with me. I would love to actually just get a background of you, Jomo, what drives you, and what work you're part of.
Great to be here, Raj. Love your focus. Yeah, so I've been pushing this rock up a hill for about 30 years, all in healthcare. Started working for a home health org in SoCal, talked my way into a data entry job. Been trying to escape healthcare ever since, but haven't been successful yet. I've always been around health data and health access. It's always just been part of the work I did. I've worked in the medical devices, and then for the last 15 or so years, information exchange. Ran into Safety Net Connect as a competitor in when they started in LA. I was running something called CenterMed Labs for a Medicaid services org in LA called CenterMed. These guys kind of came out of nowhere and rolled out a product called eConsult. And eConsult was a competitor product to a product that we sold, access tool, but in essence, it provide specialist access to primary care physicians in a way that facilitates rapid access and access to folks that don't have it.
What made you feel like, hey, I'm going to switch and try to collaborate and make this more accessible for folks? Because I think accessibility was what we were trying to solve with the eConsults.
Yeah, it is accessibility. I knew of these guys. I didn't compete or directly connect with them until about a year ago. And I ran into the founder. It's a very interesting, very successful company in their segment, but ran into them a year ago, met their founder, said, oh, I know who you are, right? The difference was when we were doing this, we were doing it with a capitated population, which is interesting because that's the success they've had, it is with a capitated population. But when they started, they were basically, this was a kind of in the wild. And the way it's manifested now, and what I'm going to talk about, I think about today is the success we've been able to measure in LA County. But I'll give you an anecdote. So a patient walks into a clinic, these are county clinics. These are staff PCPs at the county, right? In the old days, back when I was at CenterMed in 2010, the wait time to see a dermatologist in LA County for Medicaid was 14 months.
Oh my God.
For some specialties,
like a melanoma waiting for 14 months.
Right. So you're going to die. It's not going to get fixed. There were some specialties, and there's lots of press on this at the time. There were some specialties that were as long as 18 months.
Yeah.
Right. So that's a problem for us, obviously. And so what this tool does is back to that scenario. So physician takes the picture, sends it off to a queue. Within 48 hours, and on average within 24, they get a response. I need a biopsy. This patient needs to see us, actually physically see a specialist, or I need to do a face-to-face. I need more information, a question. And then the PCP answers, and there's a cycle starts. And within 24 hours, we get 3 or 4 or 5 round trips. That whole process, on average, lasts about 2.4 days. 78% or so of those initial consults don't require a specialist visit, but get resolved. Right?
Wow.
This is a cascading effect on the community, you can imagine. Right? I mean, think about, these are safety net patients, these are Medicaid patients. They've got to get off work to get to the doctor in the first place. That's a challenge. They've got to get to the doctor. Transport's a challenge. They've got to take care of their kids. Right? That's just to get to the PCP. Now they've got to go to see a specialist, and it's across town, and you can't see them for 3 months, and you've got to get all these labs done before you go. Right? It doesn't happen. Right? And really, my involvement in these guys for the last year has been helping them validate that work that they're doing in LA and elsewhere. Well, I met these guys a year ago, and I'm like, and I heard that they were up to 200,000 consults a year in LA County. So they've done more than 2 million over the last 13 years. So very, very successful. In fact, in LA County, when you need a specialist connection, this is how you do it. There's no other way in LA County that you get, and we've got 88 specialties that they have access to with a 24-hour median turnaround time. It's shocking. So what is that worth, right? And when I first asked Keith, I'm like, Keith, how much is that worth? How much value are you generating for LA County? And he said, I don't know. He said, well, it's hard to measure. They're capitated. They're staff docs.
Yeah.
And so I did a first rev of this analysis we just got the press release approved. It's coming out. We've got a quote from the chief medical officer from LA County, which is amazing because they don't put their name on things. But yeah, the value number that's created in LA County. So I'll give you another teaser. Return on investment.
Easy.
Everywhere in this conference right now. Understandable on the surface, right? A lot of bad money has been thrown after an impact or an effect. But I argue that ROI is an ineffective metric for healthcare, and in fact is a damaging metric for healthcare. If you focus on just traditional returns, you miss all the reasons we're in this room. They are not financial. Financial certainly is important, and it's how things get done. But there's a bunch of other things that get done by an effective healthcare intervention or technology that you should measure. There's returns on those. So there's these pillars, and this concept is called return on value. It's not my idea. I'm kind of weaponized it.
Where'd you find it from?
Several investment banks use it. It's exactly that. It's to measure healthcare investments in a way other than just ROI. Yeah. So return on investment is obviously a pillar, and then there's return on impact, measuring the impact to patient lives. If you divert a patient from the emergency room, that doesn't count as a traditional ROI because you didn't not spending money is not a return on investment anyways. So return on impact, and then there's return on innovation, systemic improvements, and then there's return on individuals, human impact, right? And so measuring, and health equity is in this mix. I know that's kind of become a bad word lately, right? To whisper equity, but that's important, right? And it's important to us. And it's important that we help the county measure and demonstrate the value that's being created in this program. So yeah, long story short, that number for LA County is $90 million a year, $91 million a year. It's coming out in a press release, hopefully tomorrow if we get PR approval. So yeah, it's, I'm really excited about it for my client, Safety Net Connect, because I feel like they're doing amazing work in that community and others but I want to run around and proselytize this metric for public health. Like, I want public health to use this to measure the impact that they're having on communities, because it's a tough time for funding. Like, virtually every presentation here has been about the lack of capital, and the federal government isn't funding things anymore, and we're all kind of on our own, and everybody's, FQs have to learn how to get commercial. They all come down to the same basic premise, I think, which is, somebody's got money and they want to make sure that that money is being well spent. And again, I'm not saying that everybody's just obsessed with return on investment. There are plenty of impact investors, for example, that care very much about the impact. And maybe they wouldn't mind if an investment didn't have a great traditional ROI, but had an astronomical return on impact, for example.
Yeah.
So, anyway.
So many things that I want to reflect on. And I love when I'm surprised by a concept that I didn't know existed.
Yeah.
In that there's a feeling in this conference. I've talked to a few people who feel, I don't know if a better word, like disgust in the glamour and celebration and the amount of money and resources that's being allocated for different quote unquote ideas, good or bad, people are deciding that, but it's so narrowly focused. And when you're thinking about people who are Medicaid or uninsured or vulnerable, there's a sense of how do we make them more profitable? Yeah. And it's actually a difficult question.
It's repulsive. It's repulsive.
Yeah, because I'll
say it, right? And
they're disempowered in that whole conversation. And because of how society's structured, that vulnerability means we're profiting off them in a way that's taking advantage of their situation, right?
That's right. And so I am not anti-for-profit, not very much for-profit.
Yeah.
Now, yes, there's a lot of bad scenarios where the profit motive has caused healthcare companies to go off the rails. And there's a long list of them. That said, a corporation, just because it is for profit, doesn't mean it's bad. And in fact, I was talking to folks earlier, like the social B Corp, which is actually technically a corp, but you set aside a certain amount and you've got a mission statement and such. So there's ways to do it. I don't know, a group or a society, all of us who are trying to fix healthcare, whatever mantle we want to assign to ourselves, we need to be okay with entrepreneurs making money, helping people.
Mm-hmm.
That, I think, is the fundamental question you're getting at. And there is some systemic repulsion of that kind of glam, I guess, and the ritz around startups. And frankly, I've been around this healthcare startup game since there was a game. And it did start out with consumer apps, right? Anti-smoking apps, step trackers, like wearables, that was it. It was technology for people that lived in Silicon Valley that wanted to get a little healthier. Right? It wasn't solving real healthcare problems until recently. And I feel like we're really now just starting to get into the real stuff. Care coordination, figuring out how to keep people out of the ER, dealing with systemic issues of access and racism and the things that make healthcare hard. I think we're finally walk around the room and yes, it's hard to tell what companies do from their taglines because it's all intelligent AI. But I will say, I was pleasantly surprised at how few signs had actually AI in them. I think last year was every sign had AI. It's so idiotic.
Yeah.
I think we need to be okay with some commercialism and some crass commercialism because the mission is being as long as we're all on mission, we should be all right with sequin jackets every once in a while.
Yeah.
As one walks by.
At the core of it, I'm idealist, but I love incrementalist approaches. You're like, okay, this is great work. Why is there no number to this? 91 million. Let's get that number because no one knows about the great work you're doing.
That's right.
We have to talk the language. We got to figure out how to communicate this and finding that gap and creating systems of, hey, ROI is imperfect, but so let's come up with something else to communicate this, right?
And if I have any impact on this conference, it's getting more people to understand this. I want to start a movement. And I would love to help public health systems that are trying to figure this out. And I've done some work with startups helping them go to market with this info because it's, again, they over and over again, I'll talk to a startup and they're in some sales process with some health system. And at some point, the health system says, this is great. Show us your ROI studies. And they go, or what? Right. Yeah. But that's, if it hasn't happened to you yet, it will. This is the new normal. Right. And so my premise is look, be ready for that. and say, yeah, not only do we have ROI information, but we impact a bunch of other areas of healthcare. You should know about that as well. Make it part of your sales process. And on the flip side, if this is a county or a state or a public health system, this needs to be part of how you communicate with your stakeholders, how you communicate with the federal government. Everybody needs to be on the same page, right? And I'm reading the goal, right? One of my partners had me read the goal. What's the goal? Well, your goal needs to be to create value. And if you're creating value, even if you're losing money in the short term to medium term, if the value created is incredible, then that's a decision that somebody can make. They don't just look at this as, oh, this is a money losing venture, which is what happens.
I think of lots of health equity work as not just an idea or a product, but people bringing people along.
Yes.
So part of this safety connect with eConsults, I'm sure, is the willing participation of specialists.
Yes.
What is the value for the specialists that you were able to say, hey, I want you to do this virtually rather than, bring them to the office, bill, get that cycle going, right?
Great question. So one of the things I like the most about this eConsult system as implemented by Safety Net Connect is that there are no losers. In most health tech, there is a loser. Even if it's transformational, especially if it's transformational, there's always an incumbent that needs to be dislodged. And it may be inefficient and it may be expensive, but it's the way we do it. And there's no incumbent here. Patients don't have access to specialists in rural America. I hear stories about, the state of Colorado is another customer of ours. And there's a story that Chris Cruttenden tells about this PCP in a rural town in Colorado. He's the only doctor within 100 miles. Before eConsult, he hadn't, someone needs to see a dermatologist or a rheumatologist or whatever. Good luck, right? The closest doctor's 100 miles away.
Yeah.
So now he's like, I've got this army in my pocket of specialists that I can get access to. You asked about specialists. Specialists, all LA County, and the way we typically start with the specialists you have and enable those first. Specialists can do the work they're doing now. We have specialists that work these queues depending on the setup. Whereas they can get to 15, 20 of these in an hour. Right. And they get paid for every one of those. They get paid for the visits, and the PCPs get paid. Everybody gets paid. It's not new. And the insurers pay because they benefit enormously. And so, there's ways for specialists to get access to increased revenue streams. So back to my work at CenterMed in California in the 2010, 2015 range, trying to establish specialist networks for Medicaid. And did this, right? And it's hard, particularly in finding them in California. They've come up with a way, and there's 22 states now that have reduced licensing requirements for asynchronous consults. These are asynchronous. They're not face-to-face. And so because of that, we can use specialists that are out of state to backfill. That's a massive win for everybody. Right? Because, if you spend any time in telehealth, you realize that the bottleneck for telehealth is you got to have people inside that are licensed in the state. Not a lot of licensed rheumatologists in North Dakota.
Yes.
And I know them particularly. I've done some work with them. Finding a doctor in North Dakota is really hard, especially a specialist, right? So if you can do some of these over state lines, and that's not 50 states, it's 22 states, but it's improving. That work is improving access for underserved and rural. Those exact patients we're talking about, the ones that don't have access, and that can be, South Central LA, it can be rural North Dakota, it can be Missouri, it can be parts of Texas. There's rural challenge zones all over the U.S. where there are no physicians. And then you got to go to, even in downtown LA where we have, specialists that you can, place. Access to them is hard, the networks are hard, payment is hard, overlays are hard, right? So this helps democratize and reduce barriers of entry, and everybody wins, right? Patients get access. PCPs love it because they have access. They get specialists. Specialists love it because they can practice across state lines in certain cases. So it's win-win-win.
I love it. There's a concept that somebody just recently told me that stuck with me about scaling privilege as a goal with technology. Have you heard that?
No.
It's this idea of how do you bring the floor up in equity work with technology? So this idea of by using technology, you've just raised the floor for so many patients who never had it. So you're scaling this privileged product access to specialty.
Yeah. There's basically the bottom of the pyramid tech, coming up with a new million MRI. Good for you. It's another thing to come up with a $2 disposable device that can do, clinical work in the field and plug into it. That's exciting to me.
Yeah.
That's how you're going to transform healthcare. Scaling privilege is great.
I love it. Any final takeaways about what you're looking forward to or what's up next for the work that you're doing?
I'm just really excited that we get to publicly talk about these numbers for the first time, referring to them over the last year, and I talk about them, but I didn't have the county approval to say it. I mean, they didn't block it, but they weren't endorsing it. They're now endorsing it. So I'm really excited about having conversations with folks. We're doing a lot of exciting things with the homeless, with disadvantaged, with, safety net populations. And again, this environment where just the timing is perfect going into this desert of funding it's so ironic, right? I mean, on this part of my brain, I'm hearing how all the healthcare venture capitalists are coming out of their lull and they're starting to invest again and money's starting to flow, right? At the same time that the money is drying up for public health system and for Medicaid and for all the systems this is such a weird conundrum of time, right? I'm kind of in the middle of those two worlds.
I'm excited to spread the word. It's amazing. I'm excited for this press release to be almost announced. Just so close. Thank you, Jomo, for coming on the podcast. It's been a pleasure.
Oh, it's such good talk.
Yeah,
thanks, man.
Thank you.
As always, thank you for listening to Healthcare for Humans. If you've found any value in this podcast, I have 2 quick requests. 1, please leave a review in the podcast app that you're listening to my voice in right now. It really helps others discover the show. 2, share this episode with anyone who you think might benefit from it. For easy access to all our episodes and to support the podcast, visit www.healthcareforhumans.org. There you'll find our content clearly organized by topics, countries, themes, to help you choose what to listen to next. Until next time, this is Dr. Raj Sundar, reminding you that culturally responsive care leads to better patient outcomes. See you again soon.